and we're just after 3 o'clock, so we might make a start. So I am just going to share my screen here. Excellent. Hopefully you can all see that. If you can give me a thumbs up. Excellent. Just to give a little bit of a background and bit of introduction. So welcome today. This is our second Euro Wisdom webinar, and today's topic is OR and MS, so Operations Research and Management Science for Healthcare and Gender. Little bit on our etiquette. As I said, your cameras and your mics are muted, but there's a Q&A button down the bottom of your screen. So please feel free to enter your questions in there. My name is Paula Carroll. I am the chair of the recently formed Euro Wisdom Forum. And I just want to explain to you very briefly what that is, and then I'll introduce you to our panelists. So, the Euro Wisdom Forum, it stands for Women in Society Doing Operational Research and Management Science. We recently formed ourselves together with the support of the Euro Executive as a forum, as a group, to come together to try and figure out how we can encourage and empower women and all genders to play a role in operational research. So we're particularly aiming to promote inclusivity in our actions. So we have a number of aims, you can see them written there, and really what we're trying to do is figure out, well, what kind of events and research do we need to do so that we can achieve these aims. So that's what we're about in the Wisdom Forum. So welcome everybody today to join us, and a big thank you straight away to our two panelists who have given us their time today to share their expertise. So today speaking we have Christine Currie from University of Southampton, and she's talking to us about a very, very recent paper. So we're living in very strange times. So congratulations to Christine. This paper came out very quickly, and I see it already has several citations. So well done on that, Christine. You can tell us all about it in a minute or two. And we also have Roberto Aringhieri. Roberto, I forgot to ask you to tell me how to pronounce your name, so hopefully I got relatively close. So Roberto is going to talk to us a little bit about online optimization in healthcare, and Roberto is the coordinator of the Euro Working Group on healthcare. So lots of interesting subject matter today. Just one more, oops, no, that one comes at the end. The thank you comes after we've done all the hard work. So I'm going to stop sharing now, and I'm going to pass over to Christine. And that's our panelists. We also have Nuncia there who's helping us on the admin and support. So hopefully everybody is good to go. The rest of us are going to turn off our cameras if we can here, and mute ourselves.
Great. I think I'm the only unmuted person, so I guess I should start talking. So that's great. Thank you very much for the invite to this. It's been interesting putting the slides together, because although it was a recent paper in academic terms, it seems a long while ago that we actually put this paper together, because it was right at the beginning of lockdown, well, certainly UK lockdown. So you can see from this slide, which is very busy, that there were a lot of other people involved in this work. So myself, John Fowler, who's another editor of the Journal of Simulation where the paper was published and is from the US, Kathy Kotiadis from University of Kent, Tom Monks from Exeter, Stefan Ongo, also from Southampton like me, and Duncan and Antuela from Loughborough. So there were a few of us, quite a few of us involved. Before I get going on the actual work, so this was a little bit about how it all came about. So this was right at the start of the pandemic and the start of lockdown that we put this paper together. Came about because we decided that the journal wanted to do something that in some way could help society in some way. And just highlight what the benefits modelling could bring to the COVID-19 epidemic. So we got a group of us together, started brainstorming ideas, for which Kathy and Antuela were brilliant at kind of bringing everyone together and having these right discussions in a good way. Most of the discussions took place between about 9 o'clock in the evening and 10:30 in the evening, just because several of us had children at home who we were homeschooling, so that was going on at the same point. I still have children at home who I'm homeschooling, but that's another matter. And so that was the best time to do it. So these were in some ways late night thoughts on what was going on. But I will never forget being sat in my kitchen at 9:30 at night, typing away on the Google Doc while 3 other people are also editing the Google Doc at the same time. It was actually a really quite fun experience, even though the subject matter is clearly far from fun. So thank you to all of them. It was definitely a joint effort on the paper. So that's a little bit about how it started. So what I'm going to talk about in this presentation is really go through some of the work that we did and some of the discussions that we had. Bear in mind, this was done right back in April kind of time, so right at the start of lockdown, or even in March. So it's all very early, and some of the stuff that we know now is different from the stuff that we knew then. So bear that in mind when you look at some of the challenges we came up with. So our aim was to identify challenges raised by the COVID-19 pandemic, and also to look at how modelling might be useful for helping to cope with them. It was meant as a call to arms in some ways, like here are the questions we think need to be answered, that we think modellers can answer. Come on, now get to it and let's start trying to answer them. But also a guide for decision makers as to how simulation modelling could be used to help support more informed decisions, and the full breadth of modelling, not just the epidemic modelling that we've seen so much in the news over the past 6 months really now. So this paper, just a screenshot of the paper below, and I'll put the DOI again at the end of it. But yeah, we were gobsmacked by how many people have read it, cited it, and clearly used it. So it's been great. So going to the paper itself, this is one of the figures within the paper, and this gives, I could probably almost spend most of my time talking about this picture. There's an awful lot on it. What we did in the discussion, these late night discussions we had, is come up with the key decisions that we thought needed to be made at different kind of stages in the epidemic, using some of the disaster management terminology as to what stages there were. And then we separated those into different topics. Now there is overlap between the topics, as there inevitably is whenever you try and arrange a group of things into groups. There's always going to be some overlap. But these are how we've structured it here. So we have some decisions that affect disease transmission, which I'll talk about in a moment, and then decisions regarding resource management, which is the next section, and then decisions about care. So these was how we decided we would split this up. And you can see the list of decisions down the side, the 11 decisions or challenges that we thought that we focused on here. There are things on here that we didn't look at. One of the big things we didn't look at was any economic modelling and how the impact of lockdown on productivity, etc., is going to affect the economy, and then the knock-on effects of that on other people. So that was one thing we definitely didn't look at. We didn't have the right expertise in the room to do that, and they left that as one for other people. So a lot of what we're looking at are healthcare related decisions, and also societal decisions. So they fit very well with the wisdom philosophy, I hope. And so the colours on here, every decision ended up having quite a few colours. They were related to the kind of modelling techniques we thought would be relevant. So you can see DES in the dark blue is discrete event simulation, SD in the light blue is system dynamics, ABM, agent-based modelling, in red, and then the orange is hybrid, where we're combining 2 or more of those simulation techniques together to form a model. And on the emergency management phase, you can see, for example, decision 1 on quarantine appears in pretty much every box and has quite a number of kind of points in the epidemic where it's useful. And we can see this now as we move into what's probably getting on for the recovery phase of the epidemic. I don't think we actually had one in that box, but even now quarantine is still relevant. So if we look at the first one, disease transmission, we split this into these 5 decisions. So I've written them all here. There's lots of words on this slide. It's very poor design. And also poor design for Zoom. I realised I should design slides for Zoom so that my picture doesn't sit right underneath where everyone's window of who all the participants are is. So underneath your little window below the University of Southampton is a person sneezing, who's meant to be doing the transmitting in this case. Okay, so decision 1, quarantine strategies and case isolation. And I'll go through each of these very briefly, but I'm quite happy to come back to them at the end if anyone has questions. So what we were looking at with this was reducing transmission from known positive cases and also between countries, because at that point when we were looking at this, it hadn't reached everywhere. It was very low in many countries in the world. Sadly, now it has obviously expanded and is definitely global. Decision 2 was looking at social distancing measures, and the initial aim with these was to flatten the curve to allow the health service to cope with the volume of cases, which it seemed to manage in the UK. Interestingly, when we looked at decision 3, managing the end of lockdown, we were thinking about this second peak, which is now mentioned quite frequently in the news over the past week or so, is this second peak that may be coming in the autumn. But what we were looking at then was how we kind of went out of lockdown so that we didn't have this mad rush outwards. I don't know whether even then we could really foresee the fact that people are quite nervous of coming out of lockdown. So actually it is a slower process than it would otherwise have been anyway. The other thing that we didn't look at there, which I think would be interesting and thinking about the gender link here, is how you prioritize the activities that you open up and the order in which you open them up. So thinking about this gender one, there's been a big argument in the UK about how you open up the beauty industry. The beauty industry in the UK has been quite near the bottom of the list of things that are opened up. And there's been some discussion about whether this is down to the fact that a lot of the decision makers at the top are male, and so they're less interested or less knowledgeable about the beauty industry. So those kind of decisions, particularly where you're balancing one whole industry against another in some cases, you have to look at the risks, but you also have to look at the different people who are involved. And I think that's quite an interesting, subtle point there. Delivery of testing. Now I'm about to spit in a tube tomorrow, part of the Southampton mass testing programme that's going on. It's currently a trial whether they can test the whole city for COVID-19, but looking at some simulation around measuring the effectiveness with that combined with the isolation will obviously be interesting, and estimating demand, determining efficient procedures for this large-scale testing. Again, when we were writing this was right at the beginning. They were just beginning to start putting the outside testing sites in car parks and so forth, and they hadn't really got to grips with how they could build up the testing, and that was a problem in the UK at that point. And then decision 5, targeted vaccination, how best to roll out vaccination across a community. Very positive one, that the vaccine will come out, and then making sure that it's rolled out effectively. So the next tranche of decisions we looked at were resource management, and this was mainly thinking about healthcare at this point. So how can simulation be used to manage capacity and staffing and just resources in general. So looking for things like creating capacity, managing resources for effective care, and looking at yes, how much do we need to build up these Nightingale hospitals that we used for as extra hospital provision, for example. The other one's staffing, so identifying the number of staff needed and also the support they need. So both things related to COVID-19, such as testing strategies, how many are going to be on in isolation at any one point, which can obviously be reduced if you have a good testing strategy. But also things that are ongoing, and I know that's coming up more and more in the news now, things like mental health support. So what mental health support will be needed down the line for these staff who've had a particularly traumatic few months. And then this was kind of hopeful management of regional resources. So you're likely to have, and particularly with an infectious disease epidemic, local outbreaks in different areas. So jumps in demand in different areas and geographical variations. So how do you move things around the country? And it's amazing how you forget things. So you remember the PPE was top of the headlines for many months. Toilet roll shortages, bread flour shortages, those seem to have almost just about worked their ways out. But how do you optimize these distribution networks to account for these jumps in demand? I noticed Anna Nagurney's on the list of participants, so she has some excellent ideas on that and a lot more knowledge, I'm sure. And then the other set of decisions we thought about was care, we described it as. So this is looking at individuals, so how you cope with individuals. So 3 sets of decisions that are to do with the hospital care. So in extremis, the rationing of care, who do you let into your ICU when you have to make that awful decision about deciding who should come in or not. And there was some very interesting work from UCL, from Christina Pagel, on that, which we cite in the paper. And also quick discharge, who can you discharge, what are the risks in discharging these people quickly, and weighing up those benefits and those risks. So the 10th decision, minimising the impact on other patients, balancing the impact on the wider health service with the immediate need of COVID-19. And this is quite interesting, and this comes into a little bit into this recovery phase that we're in at the moment. We've now got kind of coped with the big peak, that's on the way down. How do you ramp up the operations and so forth that have been COVID-19? There's an interesting paper by Richard Wood that's just been published in the Journal of Simulation, which looks at these kind of ideas and questions how long it will take before the health service returns to its normal level of waiting lists, for example, and it's a long time unless you put a lot of money into it. So there's some quite interesting ideas there. And then decision 11, this was uppermost in our mind, I think, at the time, as we were just going into lockdown, determining the impact of lockdown and the subsequent economic downturn on mental health at a population level. So looking at how this will have affected the population and different sections of the population as well. So school children being one obvious example. If the schools have been closed for a long time, how will that impact on mental health in the years to come, and also their education as well. So that was a whistle-stop tour through the kind of decisions. I think what's more interesting in some ways, rather than the individual decisions, although going back to them, as I said, after several months and looking at what was the interesting questions seemed to be then, and now looking at where we are now, actually a lot of the stuff has stayed the same, but there are some things that have changed, and that was quite interesting in itself. But what I think is more important here is kind of the conclusions of what to do. So the first one, bring the community together. I think that was the first one, which this kind of thing is great for. That's a picture of people within CORMSIS at Southampton. We met, had a call to discuss what we could do for a particular call, I think. And well, we all look very cheery, so that's a good thing. But bringing the community together is quite important. What I found, and I don't know whether it's true of other people at the beginning of lockdown, was this mad panic, running around with your hands in the air saying, I want to help, I want to help, I want to help, I don't quite know how. And kind of just that calmness and the coherence of a whole community, thinking about how as a community we could help, I think would be really important, and maybe is something to think about for the next one, if you like. Although fingers crossed that's not for a long, long while. The other thing that came up in our discussions was to do with uncertainty in the models, and this is particularly true of simulation, because you're dealing quite often with stochastic output, so communicating that effectively is really important. But it is also true when you've got a deterministic model to communicate what your uncertainty is about the particular parameters, and so the outcomes. And doing that effectively to these policymakers at the bottom of my screen is difficult, but it's really important if you want them to be able to make rational and sensible decisions. So that was another thing that came out. So this is a photo of the lovely decision makers at the UK and the US decision makers, and engaging with policy makers. So that was another thing I'd see, kind of looking at the models that have come out. And obviously I've seen various models and things through the journal. The ones that are going to do best are the ones where people have spoken to the decision, to policy makers, not necessarily Boris Johnson and Donald Trump, but, you know, people who are making decisions and have got all the right real information and are able to then feed that into the models and come out with sensible results. And having that communication between our community and people in policy, I think, is really important. And it's great, Christina Pagel is on the Independent SAGE Committee, which is doing brilliant stuff, and I think that really helps with raising the profile of things like OR and these modelling decisions. So the other kind of thing that came out of the paper was talking about rapid development of conceptual models, which is, you know, slightly different from engaging with policymakers on a slightly different level. But what we were talking about there was all this panic at the beginning, I felt, of the pandemic when it hit, and became more obvious that it was going to be a big thing as to how you actually put these models together, and lots of running around, kind of starting to build things maybe before you even worked out what the problem is. I think having that whole systems view of the approach and this ability to put a model together that really gets to the nub of the problem is a really important skill that I think is something that will be useful for the future, whatever it throws at us. Hopefully nothing more for the rest of this year, but we'll see what happens. So that was me, just a tour of the paper. The DOI is there, as are my contact details, and I'm happy to take any questions now or later.
Thanks a million, Christine. That's really, really interesting. Just to remind everybody, just down the bottom of your screen there, there's a little button. It's two paired text bubbles called Q&A. So if you have any feedback or questions or comments for Christine, pop them in there and we will try and answer them. So while we're just waiting for people to pop their questions in, and before we move to Roberto, first I thought it was really, really interesting, and I'm in awe that you managed to pull it together so quickly while juggling the children. So between 10 p.m. or 9-10 p.m. juggling the children. I thought that was a lovely idea, the way you were saying about collaborating on Google Docs. So I think we've got so many different technologies that we've been able to manage through the pandemic that we didn't have before. So maybe just say some little bit there about collaborating on the Google Docs. I mean, there's been a whole change to our work patterns. Did you find any other tools or anything really useful, particularly for this paper?
So this one, a lot of it, we were generally sat on a Skype call with Google Docs open. Everyone had their Google Docs open and we were typing in that and we were talking at the same time. So this was right at the beginning, before everyone had got used to Zoom meetings most of the day, or Teams meetings or Skype meetings, whatever people are using. So in some ways it was a new experience for all of us to do that. I think it proved that you don't have to be in the same room as somebody to be able to collaborate. And that's really important. And if you talk about the gender thing and you think about women with families, then that opens up a whole new range of opportunities, I think. So
it does. That's sort of where I was going to lead you to. So all these new technologies, yes, it's been a very steep learning curve, but I think for people with families, there's also been a realization that maybe I don't have to have that presence in the office, that I can do it like this. So do you think there will be a change, and will that be beneficial, do you think, to women?
I hope so. I don't think it'll just be women it'll be beneficial to. I think there's lots of ways. The environment, to women, to men because there's plenty of men who have caring responsibilities as well. Just that ability to kind of manage your own time and be in your own place and not have to travel, I think is really important. I'm not saying the face-to-face isn't also important, and I do miss seeing people face-to-face, but I think it's shown that you don't have to actually be there
that there are certainly some advantages to doing this remote working, although you were up until 10 p.m. juggling the children. So even though it's flexible, it kind of expands space. Just if anybody wants to add any questions, pop them in there. I just wanted to pick out one or two things that I found really interesting. So one was your comment about business as usual, and maybe that the beauty salons should be a higher priority than maybe some of the other things. Where did that kind of come from? Is that just in the discourse in the UK?
Yeah, so that's come partly, more recently. So in the past couple of weeks, there's been an interesting discussion in the UK about the order in which things should be opened in lockdown. I think there was some controversy because beard trimmers are allowed to be opened, but beauty facial work can't be done yet.
Okay.
And it's just speculation. I mean, maybe there are reasons why, but I think some thought has to be given as you're opening up activities as to which sections of society you're benefiting or not benefiting, to make sure that you've got this kind of as fair a spread as you can for different.
Exactly. So I think that'll come in some of Roberto's discussion as well, this idea of equity. So we design these models and who decides what gets priority and fairness. I just want to pull up one more thought, and then we have some comments coming in. So on resource management, you mentioned the PPE, which was a huge issue. And the other thing you talked about was the scheduling and the staff support. So there's a couple of things there. So we heard when they were responding to the PPE need that there was a mass rush to reduce, but it was all one size fits all, and it didn't actually fit the majority of the healthcare workers who were female and of smaller stature. So are there things within our models that we need to capture about who we're creating these resources for and how we're sharing them?
Yes, almost certainly. And also things, and the knock-on effects of having, if you've got a particularly female-dominated workforce, what does that mean in terms of, time off, etc.
Exactly, and balancing the childcare needs. So when the creche is closed, how are these frontline workers supposed to be at the front line? Who was minding their children?
Yeah.
But there's a couple of questions in here. So one has come in on the chat about how to deal with uncertainty in data integrity or insufficient data. So do you want to give that one a quick go, and then we'll pass to Roberto? So insufficiency or integrity on the data?
Yeah, so I think it's honesty is my main plea, I guess, with that. When you're describing uncertainty to decision makers, okay, you're in danger of sounding like that scientist who never actually gives you an answer, but just tells you all the things that might be wrong. So I can understand that that's not always what they want, but you can't go in and say this is the number, the one number. You have to show them what the uncertainty is there, and particularly with COVID-19 where there isn't data, so you still can't say some things about immunity, for example, that you'd like to, and that would really affect the decisions that you have to make. So you have to start looking at scenarios and sensitivity analysis around those parameters.
And then the point, as you said, about being honest, what are the limitations with the data? We can only work with the data that we have, and we have to be upfront about the limitations and making sure everything we do is replicable and all of that. Okay, so we don't have any other questions or comments yet. At the bottom of your screen in the Q&A, if you want to pop anything in there. Christine, if that's okay with you, we'll pass over to Roberto.
Yeah, I will.
More opportunity for questions. So I'm going to mute myself again now. and we'll pass to Roberto. Thank you very much, Roberto. So just down bottom left, you have a little mic symbol, Roberto, and you can unmute yourself there.
Yes, sorry. Okay, can you hear me? Can you see my slide? Yes.
Good to go.
Perfect. No, presentation. Okay, it's okay? The slides are okay?
Everything's good. Yep, we can hear you, we can see you.
Oh, perfect. Okay, first of all, I would like to thank you for inviting me. Probably this is the first, but also the last webinar that I'm going to do, because after this pandemic, I really hate the use of Zoom, Skype, Meet. There are a lot of tools that are really, how can I say, boring in some situation. They are really useful now, but in some sense, it's better to have a face-to-face meeting. I would like to speak about online optimization in healthcare. Why the title is funny and challenging? Because as happened in some research, we can find some funny problem in which we can have fun to do research, not only to try to publish a new paper. So essentially, the problem starts from different consideration regarding the delivery of care services, which can be seen as we are interested in modeling, optimizing, and so on processes, which are okay. We can be defined the healthcare delivery process. It can be defined as an healthcare structured multidisciplinary class that describes spatial temporal sequences. Essentially, is a sort of algorithm that we can manage in some way regarding the resources involved, which are not only resources, technical resources, but more common are usually human resources. So the care pathway is a sort of algorithm, okay, that can be seen as like a flow chart. Managing this care pathway is not easy in many situations, because there is a lot of uncertainty and there is a lot of dynamic. So things change quite fast, and it's not easy to manage such processes. And for instance, just thinking to a classical problem in healthcare, which are the operating room planning. We can deal only with elective patient, which is quite easy, but we can also deal with the arrival of a new elective surgical patient. Or for instance, we have to deal with delays. Delays that cannot be obviously predicted when we are planning. There are a lot of problems in the emergency department, the emergency care, sorry. The emergency care is the real field in which everything changes in a few minutes. So we have to deal with this problem. And we observed, starting this research, that online optimization it seems really promising as a methodology to deal with uncertainty and to deal with the dynamic nature of healthcare problems. But it's really essentially little applied to solve healthcare delivery problem. Usually has been used for single appointment scheduling and the management of an ambulance in real time. Okay, the outline of this talk is essentially to show how online optimization could be a methodology to deal with the uncertainty and in the healthcare management. Why funny? Why challenging? Online radiotherapy patient scheduling comes out like a funny problem that we show in a few seconds. The second time, which is really challenging, is required a lot of effort from our side in order to have a nicer solution. So, which is the radiotherapy patient scheduling. Radiotherapy patient scheduling is one of the problems which fall in the class of multi-appointment scheduling. which means that taking one appointment, we start visiting in a sequential way multiple or single resources several times, essentially. In radiotherapy, we have a number of radiation after a radiotherapy treatment consists in a given number of radiation sessions, one of each working day usually, that must be delivered in one of the available time slots provided by Linux. The problem of pointing the angle, beam angle optimization of Linux is a really important problem, which is not in dealing in this talk, but Valentina can say something for us, Valentina Cacchiani. And essentially, we receive patients that have to start the treatment as soon as possible. This is essentially the problem. Obviously, we have a release date, which is the day of arrival, and the due date, which is the last day for starting the treatment, which is set usually by the medical doctor. They say, okay, this is depending on their opinion. We say, okay, this session has to start between 5 days, 2 weeks, or depends. So waiting time in this problem is the real critical issue, because it's not only a problem of, how can I say, management of the resources, but it's a problem of a medical problem. Delayed treatment can damage the health status of the patient. So it is important to start as soon as possible. There are just one work on an online optimization, which is the one by Legrand, which is French, and Nadia Larichi and other people. The interesting part of this problem, there are many, but the most important, most interesting aspect of this problem from a combinatorial point of view is that usually the first treatment usually requires at least 2 slots. Why? The first slot is usually used to set up the Linux. So we have to find the right angle and so on. Then this setting should be memorized by the computer, and every time it has been reused. This simple aspect, this simple procedure determine a nice aspect of the scheduling. On the left, you can see the possible scheduling without the so-called hook shape, which means without the 2 slots at the beginning, the first day. On the right, we have the difference when we have to manage also the 2 slots at the first day of treatment. And this seems at the beginning seems not really important, but I don't show you the result. But this is the real difficult part of the problem. What is nice, why it is fun, this problem? Because we try to do some classic online approach, blah, 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 and nothing is able to find a good solution. Then we start to think different, and the idea was to, okay, but try to solve this problem with CPLES. But CPLES doesn't work. You need maybe some supercluster of computing to have a solution for 1 week. It's very, very difficult, because there is a lot of symmetry. There are a lot of problems in this problem. So we define really small instances, and we identify some common pattern in the optimal solution. One of these, there are 2 different patterns. The most common is the fountain effect, we call it like this, because as you can see, is if you see the colored lines in the picture on the right, the treatment seems to design a fountain that is sending the water in the middle of the fountain. Okay, what is the fountain effect? It consists in nesting the similar hooks on the right on the left. This is depicting a fountain. So based on this idea, we derive some algorithms. I will give you just really fast some idea. The first, which was the easiest one, usually the setting of radiotherapy department that you have is you have 2, 3 machines, and each machine is divided by shift: morning shift and afternoon shift. So we decided to try to replicate the fountain on that, first on the shift, then on the mountain, and then we decided to have a different approach, which is the selective fountain on machine, which means we decided to assign to each machine a different patient having the same duration of the treatment in order to have similar hooks. The result is, just to give an idea of that, give it this animation. So this is the fountain on machine versus the selective fountain on machine. So at the beginning, we start nesting the patient. That for this example, we suppose that the release date is 0. And the first difference is at this step when we start the patient in a different way for selective in foam, we call foam, in the fountain on machine, a selective foam on machine. The idea is to put together patient with the same duration in order to avoid what? To avoid at the end this effect. If we don't consider the duration of the patient, we can waste many slots, which are could be really useful to be effective and efficient in our solution. So this is an example. To better see this example, you have to rotate your monitor. Sorry, but otherwise it's not really useful. It's too small. And there are the 5 algorithms that we tested. And as we can see, obviously, the last algorithm, so the selective fountain on machine, is the most effective. It's able to treat in time all the 3 categories of patients, which is the quite common setting in literature. And the waiting time is really, really low, even if compared also with the other algorithms which are not so effective. The algorithm remains effective in the other situation, overloaded scenario, which means that we have a demand built in terms of available slots. So we generate a number of patients requiring the 100% of the available slot in the horizon period. And again, the patients are treated in time. The percentage is quite good, and especially with respect to the other algorithm. Sorry. Why it works better than the other? Because the selective fountain machine is able to maintain constant, in some sense, the green line, the constant during over time, the average waiting time for each patient. So this is just the first part of the talk. Why this is funny? Because it's the solution is quite funny, because it's not easy to arrive to this type of solution, but the problem is really challenging. At the moment, we are not able to find a good solution with hook. If in the same, for instance, if in the same model we do not consider the hook, the solution are really fast, and it is really effective. So this is the hook shape is the, how can I say, the really component of the problem which is make it really hard. Let's go to the second problem. The second problem arises in the management of the emergency department. This is a really difficult problem. There is a huge literature on this problem. Maybe if you can make a search on Scopus with the emergency department and some other keywords, you can find at least 10 or 20 papers every year. Reducing the search on optimization, simulation, management papers, obviously. Not if you consider medical paper, you have thousands of papers. Which is the main problem when you are in charge of managing emergency department? The big problem is overcrowding. Overcrowding means that you have a lot of people waiting for something in your emergency department. Okay, so maybe are people waiting for the first visit by the medical doctor, or people waiting in the hallways because you don't have a much bed or whatever. And this is a problem, a real problem from a medical point of view, because when the crowding level, obviously doctors are, medical errors can increase, there are delays in the treatment, and there are other problems, stress for people working in the emergency department and so on, because decrease of productivity, because of stress and so on. So we can summarize the effect of overcrowding is like a locust for farmers. It's a big problem. So there is a lot of, how can I say, tentative also from the medical literature to, how can I say, to frame the idea of how we can deal with overcrowding. And there are a lot of solutions. One of the most famous is an index is called the NEDOX, which is a number. After the end, there is a formula with come out a number. This number determines a color, and this color is the level of overcrowding of your system. Obviously, this doesn't work from our point of view, so we need something more, which is the big problem when dealing in this situation. If we consider the pathway of an emergency department, is really simple. There is an arrival. After the arrival, there is the triage. So the nurse or a doctor, maybe at the beginning of his career or her career, made the triage. So then the person is waiting. Obviously, if it's a red code, is not waiting. Then you wait a lot, sometimes for a visit, the first visit, and then the medical doctor say, okay, this is your problem. We have to do some test and care activities, which means exam or whatever and so on. After the test and care activity, we have the reevaluation. In the reevaluation, you come back to your doctor, and the doctor say, okay, you are okay, you are not okay, you have to be recovered in the hospital and so on. There are different situations. One of the situations that you start another cycle of test and care, and then another evaluation and so on. So at the end, you have a discharge. In some way, you can you be discharged by the emergency department. This is very simple. If we consider the pathway of in an operating room planning, an operating room theater is really more, how can I say, more complex. There are many more activities that we have to consider. Which is the challenge? The challenge is to how to model properly the wide variety of different patient paths within this generic but simple care pathway, which is the real problem. Sometimes this affects also some proposed in a simulation model that I see. Is the problem is that to model this simple pathway, this depends also from the data that we can have in our approach. Usually in literature, you can find a strong assumption and simplification, which are touching the most important aspect of the system, which means the usually neglects the interdependence between activities. Okay, you are doing X-ray now because you have done something before. This is important to keep trace of this situation when you are interested in managing the pathway of the emergency department. We found only one paper by Luscombe and Kozan try to deal with the real-time management optimization of the emergency department. They use a different approach. This is an example of a wide variety of patient paths. As you can see, this is called the spaghetti process. We are Italian, obviously, spaghetti process. And essentially, this gives you the idea of how complex is the possible pathway inside of an emergency department. You coming from this path, and you go in this chaotic situation, where essentially you can in A means the entrance, Q, P, and O is the exit. In between between the entrance and the exit, you can do everything in every order, essentially. And this is really difficult if we are interested in managing the pathway of each patient. These results are obtained by a case study, which is an emergency department sited at the hospital of Cantu. Cantu is a city close to Como. So we try to think different again, and the idea was the following. First, we need a remark. This is the situation in a standard, in every moment in an emergency department. We have, as you can see, after the visit, we have some, they are not so big, but there are some balloon with a number inside, which means that are patients waiting for a service. It could be therapies, laboratory exam, X-ray, short stay observation, other activities. So if we were interested in managing the resources of the emergency department, we know that only the people in the queue that we see after the visit, we know only for this patient which are the required resources. For all the other patients, we don't know. So especially when the overcrowding, the crowding level in the emergency department increase, we have a lot of patients in the waiting room, and we don't know nothing about that, those patients in regards with respect to the use of the resources. So we cannot manage in an efficient way the queues for the resources without knowing which are the demand of such resources. So we have to find a solution for that. So we will, the nice thing is to have a sort of prediction, to have a prediction saying which are the resources that likely should be used by the patient. And this is what we have done. And this is the picture will highlight this fact. So we have, again, we have the same patient before that we seen before, which are in queue, which are waiting for a service, for therapies and so on. And then we have other patients that are clustered, before are clustered, so the dashed circle. And for each circle, we have, how can I say, we have an estimate of the probability of using some resources independent on the information that we have on triage. So we collect some information on the triage and we made a cluster of this patient. Then we use a process mining approach in order to have information about their process. So this is the idea. This is the basic idea. Using process mining. The idea is we have the entrance of the triage, and then we made some path inside the emergency department. This is a sort of decision tree. For instance, we have in the highlighted part, sorry for the spoiler. And we have, in this case, where is it? After we have triage, visit, lab exam, which is the F, then we have a therapy, the L, short stay observation, which is the N, and then a reevaluation, and after there are some infrequent activities that we are done. So this is the idea of our approach. Try to depict step by step each operation of the patient. To do this approach, first we cluster patient using the information at the triage. This is my small contribution, my gender angle, as Nunzia told me by email, and we discussed it with the medical doctor in charge of the emergency department in Cantu, which is Alessandra, discovered that there is a difference respect to sex. So we have a different treatment regarding the sex. In this case, the difference are regarding the letter H, which means X-ray. means that following this path is a time-dependent, non-urgent pathology, which means that a pathology for which we need to do every step, the step of the care process after a period of time. We don't have to wait too much. And it comes out that in that process, which is obviously gender-free in some sense, there is a difference in respect to the female and the male. And we would like to, how can I say, we would like to understand why, because Alessandra is committed also in the school, in different situations to, how can I say, to avoid such a situation. It was really worried, oh, in my emergency department happens a difference, it's not really okay. But at the end, Alessandra has some problem with the management of the hospital, so decided to left the work and to change place. So we cannot understand which is the problem. What we can say that it's touch a really limited number of persons, and it probably depends on we don't verify the situation, but probably depends on the time of the day in which it happened, because the X-ray is not in that hospital, not available 24 hours per day. This is the first justification that we find. But as I told you before, we cannot go more in details. And after the clustering, the idea of clustering is to reduce the spaghetti process effect, in order to have patients which are more close in terms of path inside the emergency department. So we determine we call it the hybrid activity tree, because at the beginning is like a decision tree, but at the end we have a graph with to model the less likely activity, in order to avoid to have a tree with really long tree. So this is our ad hoc process mining model that we trained on data from 2013, 2015, and then we tested the, how can I say, the prediction, the probability provided by the model on data in 2016. How we can do it? We developed a really detailed simulation model, which is nice with respect to the talk of Christine. This is a discrete image simulation model based on agent-based and semantic, because we need to how can I say, to model aspect of the everyday job of the medical doctor, of the nurses, which can be represented only through an agent-based simulation model. On this simulation model, we embed, inside this simulation model, we embed online optimization algorithms, which are essentially the, how can I say, the sort of algorithms that continuously rank the patient on the queue with respect to the access of the resources. So we define a priority score, which is based on urgency, waiting time, and the information, the probability that comes out from the prediction of the hybrid activity tree. And then we rank the patient accordingly. We define several policies that the online optimization algorithm should follow. And the most effective one are two. The first one is to promote patient needing specialized visitor exam that are not competence of the staff. And the other one is to waiting for the hospitalization. Well, what is the meaning of this policy? An emergency department is not, how can I say, is not only a self, they don't have all the capability inside the emergency department. Usually you can ask something for to the rest of the hospital. in this case, specialized visit or some special exams. And so you have to wait, because you cannot decide when, but you have to wait a sort of call from the other ward and say, okay, you can come with your patient. So you cannot handle this fact. You have just to wait. The other aspect is similar. So, in regards to those patients that are waiting for hospitalization. Those patients usually wait in the short stay observation room, which essentially is a room with 5, 6, depends, 3 beds, in which patients are under control of the nurses. And sometimes it happens that those patients has to be hospitalized in some ward, but you should wait the fact that the bed will be available in 1 hour, 2 hours, 4 hours, depending on the organization of the rest of the hospital. So the interesting part of the result, these are some statistics which are not important, a part of the usual peak early in the morning. The results are interesting because we can see that the best policy to improve the use of the resources are those related to the connection of the emergency department with the rest of the hospital. In other words, we can say that the inefficiency of the emergency department weakly depends on their internal organization, but strongly depend on the organization of the rest of the hospital. So the connection between the wards inside of the hospital. What we can see here, this is the average value on 2016. The green line is the baseline, so the current situation that we replicate with the simulation model. And then the other line are the 2 policies that I showed you before. We present a result on different time frames, and we can see that the policy are really capable to reduce the waiting time, especially when we have the peak of demand. So the frame number 3 is between 8 o'clock and 12, as you can see, is one of the peak, 8 and 12 o'clock. More interesting is the second one is the same analysis, but restricted to all the crowded days, which means we selected the 46 days along here, which we define as crowded. Which is crowded? Crowded is when the maximum length of people waiting in the waiting room are greater than or equal to 10. So there are only, maybe depends on the point of view, only 46 days in 2016 with these characteristics. In this case, we can see that we are again able to reduce the waiting time, and from the graph, from the picture, you can see that is reduced by 50%, almost 50%, because we are able to, how can I say, to know in advance what the patient needs, likely need. So we can manage the queue, we can manage the resources properly. So just conclusions, sorry if I was too long, but in our experience, it seems that online optimization seems a suitable methodology to cope with the intrinsic uncertainty and the dynamic nature of healthcare delivery problems, which is the message in about why this is our idea. We can see that a suboptimal decision, because we are using essentially greedy algorithms, not so sophisticated algorithms. A suboptimal decision at the right time could be enough, and sometimes it's better, than the best a priori stochastic-based decision, okay? Often, this is the only computation option that we have, because it's very difficult, for instance, how we can model from a stochastic point of view, the mathematical model to manage the scheduling of the patient in an emergency department. It's not his task. Usually we can use, I can say, Markov decision process, but we know that are really difficult For everybody which are more interested in ambulance management, we know that there are different models based on market decision process, but they are really, really difficult to solve.
Roberto, that's really, really brilliant. I'm just very conscious of the time here. So
yeah, sorry, but it's finished. So
excellent.
Okay, no, but that's the last slide, essentially. The fact is that online optimization can take advantage of the complete knowledge of the past. So I'm arrived in a moment of my path, and I know why, which is a no in a normal or standard stochastic approach. The main challenge is to include the look ahead, because the effectiveness of our approach for the emergency department is the possibility to have a look ahead of the patient. And so we have an evaluation of which are the resources that most likely will be used. So this is the end of my talk. Sorry for to be too much long. I'm not.
Thank you very much, Roberto. That was really, really interesting. So just everybody to remind you, I know we're just over time a little bit, but if you have any questions or comments for Roberto, if you want to pop them into the chat there, we'll call them out. Christine, just before, I know you have to leave now. So Christine, if you want to turn on your mic and your camera again, I think there was a lot of overlap between some of the themes between yourself and Roberto, and Nunzi is with us there. One thing I thought was really interesting was where you did find that gender angle, or that there was something in the data that people weren't aware of. So one of the things that I would say is that when we're not aware that there are biases in the system, when we do our optimization, if we just encode the existing system, we just further encode and trap in the bias. So it's probably something we need to be alert to. But Christine, maybe just, can you think back to your talk and Roberto's and the two of you there, maybe just to draw them together, because I know people are probably wanting to head off soon. Was there anything particular in Roberto's talk, Christine, that you thought would help you with your work? Do it that way.
I think there's a lot there. I mean, there's lots of really interesting optimization there. It's hard to pick on one that's going to be relevant, but yeah, I think kind of using some of these ideas and the ability to adapt them to the new situations is vital, I think. Yeah. I mean, healthcare is going to be completely different, it seems, for the, well, not completely different, but there's going to be some big changes to healthcare over the next 10 years, I suspect.
I suspect there'll be a lot of streamlining of things, and this, the advantage, Roberto, that you were picking out, that using optimization techniques, that you were able to connect the wards, whereas otherwise they're operating suboptimally because they're disconnected. So I think that for us in the OR community is a big opportunity. Can I just throw it open to our panelists as well? So it's been quite quiet today. So if anybody has any comments or questions, in our chat button there at the bottom, or in our questions and answers button, if you want to pop anything in there. So everybody's quiet. So very much. So Roberto, if you can stop sharing your screen for 2 seconds, I'll just bring back up our last few bits and pieces. So thank you very, very much. That was really interesting. We are slightly over time, but I just want to thank again our speakers. If you do have any comments, feel free to pop them into the chat there. But I just want to maybe conclude today's session, if I can. Little wake up, by thanking our panelists for today. So Christine has to head off shortly, so she has to go juggle her children. Well done, Christine. Thank you very, very much. It was a really interesting paper, and as I said, it's already been quite highly cited, so it's only fresh, hot off the press, so that bodes well. I did pick out one quote from that paper, and it was "Good teams." I can't read the quote because I have something in front of it there. What does it say? Good teams help solve difficult problems. And in your paper, you were actually talking about the women in Bletchley who had, so you had called it a call to arms. And I think the whole COVID crisis, people wanted to help. There was an immediate need or feel to want to respond. But I think that's a very nice quote about good teams being able to come together to solve difficult problems. And Roberto, I picked out a quote from one of your papers that I found really interesting. And it was this one: equity is one of the most challenging concerns in the healthcare system. And I think that's quite right. So we do our optimization, but we have to pick our optimization functions. So Christine talked about getting the ear of the policymakers. So who gets to decide what these objective functions are? I think they will determine the solutions that we can create from our models. So Christine had also said we need to be aware of the limitations of our data. We also need to be aware of the limitations of our models and that we're not encoding further biases into the system. Yeah. So I'll just go back to our chat function there. If I can, I'll stop sharing just to see, are there any last comments or questions? And everybody's quiet today, so I think they have a lot to think on from your presentations. So again, thank you to our speakers, thank you to our support people today. Did I show you our slides? So Nuncia, Paul in the College of Business, and the Wisdom PR team, and all of the Wisdom subcommittee. I will actually just share my screen again to show you the next steps in terms of what we're doing in Wisdom. So thank you to our panelists for today. Thank you to everybody for joining us. We do have a whole program of events and research that we're trying to plan. We're a small group. We're open to collaboration. So anybody that's interested in joining us and working with us, we'd be very pleased to hear from you. We have a new initiative that we're starting soon. It's a Women on the Walls initiative, giving visibility to women at the early stages of their career in OR. We've also published a white paper on promoting gender equality and inclusivity in Euro activities. We have more research, we have more activities planned, and you'll find all the details of everything up on our website, and you can contact us at our email address there. So we'll finish at that for today. Thank you very much for everybody for joining us, and thank you especially to our panelists. Bye-bye, everybody.
For the invite. Thank you very much.
Bye-bye. Thank you very much.
Thank you.
Thank you.
Bye-bye.
Bye-bye.
Thank you so much. Bye.